Okay, these are peripheral retinal lesions that predispose to retinal detachments. And you do need to know these, and you kind of need to know some of the numbers I'm going to show you, because it gets confusing, and you'll see why some people do things that they do which are probably inappropriate. So again, the ora serrata. So what we're going to talk about is cystic retinal tufts, retinoschisis, asymptomatic holes, lattice degeneration, and symptomatic tears. And those are the things you need to be careful of. And again, the biggest difference between these and the other lesions is the vitreoretinal attachment. So it's almost impossible to get a retinal detachment or retinal tear without vitreous traction. Those of you who are going to do retinal surgery will learn that the main thing we do surgically, like I was doing this really nasty diabetic on Wednesday, and I relieved all of her traction. And even if there was a small hole, which I don't think there was, but there was an awful lot of bleeding. So even if there's a small hole, that won't cause a retinal detachment unless there's traction. If you leave traction behind, you might as well throw the eye away because it's going to turn into garbage. So that's why it's so important if you have a complicated detachment with traction that you have to relieve all the traction before you get it detached. And that's why macular holes don't cause retinal detachments, because there's no traction there. So vitreoretinal traction is a big deal. The vitreous is normally attached, and I believe you need to know this too, at the vitreous base, the optic nerve margin, blood vessels, and the macula. And then if there's lattice degeneration, it's attached there. So those are your typical vitreoretinal attachments. And significant lesions all have traction. So a cystic retinal tuft is bigger than the little non-cystic ones. I saw a patient 2 weeks ago who was referred with a peripheral lesion. It was just a cystic retinal tuft. They're often pigmented. They're present in all ages. They're extremely common. They're you'll see them in 5% of eyes clinically, but they're in almost 60% of eyes on autopsy. And then this is where it gets weird. So 50% of retinal detachments have predisposing lesions. And 10% of retinal detachments are associated with cystic retinal tufts. So what happened up until Norm Bayer did a lot of his work, a lot of people would take these predisposing lesions and say, oh my gosh, 10% of retinal detachments, we need to laser all these to prevent retinal detachments. So that's why up until, still in some parts of the country and some parts of the county, but it's not really standard of care to laser all of these lesions, because even though a lot of retinal detachments are associated with them, the risk of one of these people getting a detachment is pretty low. So it's going one way and the other. I'm sure there's a term for that. So the risk of a retinal tear is only about 0.2% or 0.3%, and the risk of a retinal attachment is about 1 in 1,000. So if you treated 1,000 of these cystic retinal tufts, you might prevent one detachment. So that's why it's really not appropriate to treat them. What you'll notice, though, and you might be able to see this now, is now that I've shown you these two slides, which I love, you can see the slides with the lights on, can't you? Yeah, otherwise I'd fall asleep, and the videos won't look very good either. What you'll notice when you look at tears is sometimes a retinal tear has got that little thing on it at the tip of the tear, and that's where there was a cystic retinal tuft, which is why they got the tear. So that's these little things on the end, like there and there, those little white things. So those are cystic retinal tufts where the retina pulled and tore there. And once you know a look from, you see them. It's like many things in life, once you're aware of them. And there was an interesting paper done, and I should put the reference here too. This was a Japanese group where they did, it's very hard to look at the vitreous under a microscope because it's liquid, but they froze the eyes. And they did these sections frozen, and they showed a bunch of vitreoretinal attachments. And one of the things they showed was this picture on your right is a frozen picture showing the vitreous attaching. You can see the strands coming into that cystic retinal tuft and how that would be a problem. Typical retinoschisis is the flat kind, and then reticular is the bullous kind that you'll see more often. But you can just call them retinoschisis. Retinoschisis is common. 3% of the population have it. Over 47% of the population have it. It progresses sometimes, but not usually. But some retinoschisis can progress. Only 1 in 1,000 people with retinoschisis develop a symptomatic detachment. But asymptomatic detachments are very common. So they're almost 10%. You don't need to treat the asymptomatic detachments. Inner breaks are what you'll see. So this is where it gets tricky treating retinoschisis. What you look at a patient with retinoschisis, and any tear you see easily is an inner break, and those are completely unimportant because sealing those won't help the patient. But the outer breaks are about 10% of people, and those are the ones that will develop detachments, and this is what the outer breaks look like. So the outer breaks are these weird, like lighter areas or darker areas inside of lighter areas, and what you're doing is you're looking through the inner retina and seeing this sort of atrophic big hole in the outer retina. If you're going to buckle these people or fix them when they have detachments, you got to fix the outer breaks, or you can't get them, or the retina won't stay flat. And retinoschisis detachments always bother me. That's why it's nice to just observe them. You don't have to, unless they're symptomatic, you don't have to operate them, because operating is a problem. You need to know how to differentiate retinoschisis and retinal detachment. And this is pretty much, retinoschisis is bilateral 60% of the time or more, it seems. So if you see it, and it's almost always infratemporal, which is not on this slide. So if you see retinoschisis, if you see anything infratemporally in an eye, you just look at the other eye infratemporally. And that's why you have to dilate both eyes on patients. One of them, hundreds of reasons to dilate both eyes. You can look for the scotoma. I mean, if you're not going to do a visual field on your retinoschisis, because retinoschisis is a truncation of the inner retina, it's an absolute scotoma. Retinal detachment, because the nerve fiber layer is attached to the photoreceptors, it's less of a scotoma. The vitreous will be clear because there's no thing, there's no vitreous process, it's just retinoschisis. The surface is smooth, this dome shape, but the biggest one is the RPA change on the bottom. So what you'll see, and retinal detachments do look different, although actually I have to say, these chronic peripheral ones don't always. We had a patient recently that in one of the clinical studies with the detachment that's driving everybody crazy, and it was just it looked smooth, it didn't look corrugated. But the demarcation line is a big deal. You do not get a demarcation line with retinoschisis. The retinoschisis, because the outer retina protects the RPE, there's no like retinal RPE interface to irritate it to cause a demarcation line. So anytime you see a demarcation line, there's a detachment there. And it's pretty common, but it doesn't mean you have to do anything. You can do a laser spot test. You don't need to treat retinoschisis. You definitely don't need the laser, but if you're curious, I haven't done a laser spot test in years. What's great for retinoschisis now is the OCT. If it's posterior, you just put your scan down there. But again, you got to hover over the scanner person. But you put the scan, you put a line down there, you get it over the retinoschisis, and all you need is, it doesn't have to be high resolution, you just need a quick image. And you can tell it's retinoschisis. So retinoschisis is another one that's about 10% of retinal detachments. So cystic retinal tufts are 10% of detachments have cystic retinal tuft, 10% of detachments have retinoschisis. And then asymptomatic retinal breaks are kind of predisposing lesions, but not much. This is 2% of them lead to clinical detachments. You'll see asymptomatic retinal breaks all the time. 6% of eyes have them. Most of them are with lattice degeneration. Some of them have traction. A lot of times there'll be a subclinical retinal detachment, which I believe is up to 2 disc diameters of fluid around the hole and usually anterior to the equator, but there is a definition for subclinical retinal detachment. And this sort of shows you what asymptomatic retinal breaks look like. And that's for asymptomatic breaks. And then finally, lattice degeneration. Lattice degeneration is a big one. You'll see this in a lot of people. It's all the time, and it can be hard to see. It looks a bunch of different ways, and it is an important lesion for retinal detachment. So lattice degeneration is an area of retinal atrophy where the vitreous attaches at the periphery of the lesion. It's usually parallel to the aura, but it can be radial. And what you're seeing in this, the vitreous is this green stuff up here. So that's the lattice, and that's the vitreous attaching to the lesion here and here. And that's the lattice degeneration in the middle. So it's different from paving stone. So that's a picture of lattice. It gets the name because the blood vessels over it kind of turn white. So it looks like a lattice work. It can be white. It can be hard to see without depression. You can have holes in it, like the image on your right. Sometimes you can see the vitreous protruding from it. It's very common. Clinically, it's almost 10% of patients. About 8% of patients will have lattice degeneration. At autopsy, it's in 20% of eyes. So a lot of these numbers are much higher, and I believe, again, those were Dr. Fuss's articles. And sometimes you don't see it without depression. So the picture on the left is lattice degeneration where the patient wasn't scleral depressed. In the picture on the right is scleral depressed, and what you'll see is this excavation. Again, it's not easy to see, but you get used to looking for it. Some people have a lot of lattice degeneration. You'll see it all over the place, and some people just have a little bit, and it rarely causes retinal detachment. So I guess 1%, that's lower than that. I guess 1% of patients with lattice degeneration will get a retinal detachment, and 7% will get a subclinical. So a small retinal detachment isn't uncommon, but a big retinal detachment is less common. And this shows you subclinical detachment. So you have 2 disc diameters of fluid around it, and then anterior to the equator is considered subclinical. So the reason people get so upset about lattice degeneration is 30% of retinal detachments have lattice degeneration in them. So it's super common in your retinal detachment. So you've got 10% retinoschisis, 10% cystic retinal tuft, 30% lattice degeneration. And when you see the lattice degeneration in a retinal detachment eye, the other eye has about 25% of the, or no, you see any retinal detachment eye will have lattice degeneration in the other eye about 25% of the time, even though it's only present in 8% of the population. So the risk of a retinal detachment in a fellow eye of anybody is about 10%. So when someone has the risk of retinal detachment in the general population is about 1 in 20,000. It's either 1 in 10, I've seen 1 in 10,000 and 1 in 20,000, and I'm not sure what it says in your book, but a phakic patient has an extremely low risk of retinal detachment. If someone has lattice degeneration or one of these predisposing lesions, it goes up to maybe 1 in 1,000 to 1%. If they have a retinal detachment in one eye, then it goes way up. So the risk of, it's like anything in your body. If you had a retinal detachment in one eye, your risk of retinal attachment in the other eye is very high. If you treat all the lattice degeneration in the other eye, you probably do reduce the risk of retinal detachment. So there's some issue of whether you should treat lattice in the fellow eye of someone who's had a retinal detachment in one eye. And I go both ways. I'll sort of tell you my algorithm when we're done with this. There's not much data on other people. You know, if someone is going to have cataract surgery, they're going to have YAG, they're myopic. You know, should you laser their lattice prior to the procedure? I never do. I think in a lot of the peripheral retinal literature is old. It's not sexy. It's not that interesting. It's very hard to photograph, and people have other things to do. So the old stuff that said to treat it was back before we had, nowadays we can fix retinal detachments pretty easily. So I think that's why we don't treat the lattice to prevent a detachment, because if someone gets a detachment, it's not that big a deal for us to treat it. You can do 360 laser on people with lattice degeneration, and that reduces the risk of retinal detachment in fellow eyes. So you can reduce the risk of retinal detachment from 10% to 5%, but the reason I don't like laser is some of the eyes that I've been unable to fix their retinas, which is not, we can fix like 99% of retinas ultimately. The eyes that are hardest to fix are the ones that have had a bunch of laser, because the laser can make a retinal detachment very complicated to fix. And what I always tell people, if you imagine fixing a retinal detachment is kind of like making your bed. It's sort of like fluffing the sheets. You just want to smooth them out and then stick them down. All the laser spots in someone is like someone's holding those sheets. So every time someone does, especially posterior laser, if someone lasers posteriorly and then the person gets a retinal detachment, that's an area that's going to keep the retina from going back on again. So every laser spot is your enemy when you're fixing a retinal detachment. It's just so I'd rather fix the detachment than try to prophylax it. What I do is if someone has a retinal detachment in one eye and a little bit of lattice in the other eye, I'll usually suggest that we laser, but I usually leave it up to the patient. And I always wait till we're done with the detachment. I think I have one person floating around now where we need to do that. But if it's extensive lattice, I usually don't laser it, because I think lasering extensive lattice is just so hard on the eye. But that's not, and you'll see people that, and the reason all of these things, the reason treating things doesn't reduce the risk of detachment to 0 is because at least half of the tears that occur in people with predisposing lesions are not where the predisposing lesions are. And that's what this slide, this is showing these invisible attachments. So you can't see all the attachments, so you can't treat them all. So that's why you can't reduce the risk of detachment to 0. So in conclusion, for the most part, this is actually symptomatic tears aren't in this lecture, but so for the most part, most of these predisposing lesions don't need to be treated. You know, the only exceptions, I think, are people with a fellow eye retinal detachment, and that's probably it for peripheral retina. So your predisposing lesions are the ones we talked about: lattice degeneration, it's going to drive me crazy, retinoschisis, and cystic retinal tufts are kind of the three big predisposing lesions.